Welcome to the Beverly Hills Plastic Surgery Podcast. This is Dr. J. Calvert. Today, I'm in the studio once again, back from Paris, with my very Parised out co-host, Dr. Millicent Rovelo. How are you doing?
I'm doing excellent. How are you?
I'm great. I guess we're not really Parised out, are we?
No. For me, that would be very hard to do.
I know,
to
it was
have
great.
too much Paris, but we are out of Paris.
It's true.
Sadly. But we're back. We're back in Beverly Hills. I mean, there are worse places we could have landed.
That's true.
So, all good.
It was a great meeting. Very happy that we made it back safely. We're back in the saddle doing surgery, busy as could be. And I want to talk to you about the big panel that you did, because there were a couple things that came to light at this meeting. One, the rhinoplasty sections are just really, really niche sections. There just aren't many people that are really that interested in rhinoplasty.
It's a very small community. So even at the most attended surgery, plastic surgery, cosmetic surgery, rhinoplasty surgery meetings, it's a small group of surgeons that do what you do.
It's like an orphan specialty. I'm just over there like fixing my noses and doing my thing, and everyone's like, good for you, man.
Yeah.
Keep going. You're the man. I mean, there was like, really, when we started off that first session, there were literally like 6 people in the audience, and there were 6 panelists. That's a total of 12 people. I mean, really. And then there was probably 4 staff members. So, and the room was set to hold, 200 people. No dice.
No.
Didn't need the 200 seats.
Nope. But the breast panels.
Big news.
Yeah, there's a lot more people in those. Sorry.
Yeah. So that's what I wanted to talk about. Like, I don't think people know what it is that you do, because there was sort of like, I'm talking to, these big people from ASAPS and the big people from IMCAS, and they're like, Dr. Rovelo, like, she's really got her stuff down. I was like, it's really only the surprise in your voice that hurts. Like, duh. Like, who are you talking about? Yeah, she's got her stuff down. I don't think they realize kind of what an expert you are.
Well, I'm in my little corner. I'm doing my I want to say my little surgeries. I'm doing my big ass surgeries. And I just, I don't make a lot of noise other than the fact that I have a podcast and 2 billboards. Other than that, I'm pretty low key.
Pretty low key. But it's true. I mean, I don't think that the leadership of I know that IMCAS is starting to get the point, because they put you on a few big talks and you did really well. But I really feel like, I think that there's got to be a little bit of summary of what it is that you do. And I think people need to understand that doing these complex breast reconstructions and complex body cases are not easy. This isn't like the plastic surgery 101 type stuff that you do right when you finish a residency. I mean, you've gained significant expertise with very complex stuff from doing a lot of it.
Right. And that's mostly what it is. I was fortunate enough that when I did come out of residency and training, I was put in a position where I could do a lot of these really complex body cases. Certainly not for like the faint of heart or, the shy. And you just do them. I mean, they're handed to you. You do them. The patients come to you. They have these needs. And so you do the cases. And I've gotten to really like and excel in the complex breast reconstructions, the revisions, the secondary cases, and then also these big body cases as well.
But why are you good at it? This is the analysis point here, because I know what it is. See, like, you have to realize, like, when I saw you start operating as a resident, I said, this one is different. I said, the surgery is strong with this one. There was like this real talent, which you brought from LSU.
LSU General Surgery.
Right. So like, and for anybody who doesn't know, like, I trained at Pittsburgh, where a lot of the guys and gals that came from LSU landed in Pittsburgh with me. Guys like Lloyd Champagne and Joe Zaldos and Ken Odene, good Cajun guy from Louisiana. And these guys they operated circles around the other residents. They really did. And that's the nature of LSU. And so when I saw you operating, I felt the same way. And so why is it that you were able to create these systems to do these complex cases? How did that happen?
Well, if you were to ask me, and you are, my initial gut answer, and perhaps it's a little self-deprecating, is that I'm stubborn. I enjoy a challenge, and I'm not going to back down from giving it my best. And so, yes, I do tend to take a long time in the OR, and that's what I'm known for, because I refuse to stop or not do enough to get to get the patient and the results to be as perfect as I possibly can. And I'm too stubborn to back down and say, "Oh no, it's too hard," or no, "Oh no, I can't do this." It's like, okay, I'm kind of like that snail that gets to the end of the race eventually. Like, just give me time. I'm gonna get there. I'm gonna get there. I'm gonna do it. I can do it. I can do it. And then it gets done. So I refuse to back down in the face of complex or difficult, because I know how I can get there. And it's just a matter of putting your nose to the grindstone and doing the work to get that result.
And I think there's something to be said for reps, for experience, and
Oh, well, yeah.
you've done
There's
a
a
ton of reps.
Yeah. I'm definitely now at the place where I can see a patient, know what they need, know what needs to happen in surgery, know what tweaks need to be made in the technique to get the best possible result.
So for our patients that are out there, like there are all these people that listen to this podcast, and we got hit pretty hard when we were in Paris with lots of people saying like, "Oh, I love your podcast. Listen to this. I listen to that. This episode was great." What is it when you're sitting there and you're, let's say, as a patient, you're looking for a surgeon, and this happens all the time. When I say, "Well, I don't live in Beverly Hills. I'm not coming there. How do I pick that surgeon?" How does somebody who needs, breast reconstruction, do they just go with what's on their, do they look on their insurance panel and say, "Oh, this is person on my insurance panel," and then do they say, I need the best person? How do you identify the person who's really good at the things that you do?
I think it involves a little bit of legwork and grunt work on the part of the patient, but in the right channels. So if you're going through insurance or for an insurance-based case, like the patient I had today, his insurance company gave him 22 pages of doctors. He went through every single one. He found me on like page 7, and when he finally looked me up, he was like, "Oh, that's who I want." So he fastidiously went through every single person on that list until he found one that he liked. Looked at the befores and afters, the website, the social media, the podcast. So if you're given a broad list of options within, say, your network, spend the time going through them and doing exactly that. Most importantly, as we say all the time, look at the befores and afters, because that's probably very similar to what you are going to get. So you have to like the final result because you're probably going to get something similar. And then once you've narrowed it down to, 2 or 3, and then you go and you meet with them in person, and you will know pretty soon whether or not that's your surgeon. Like it's that if you're at all listening to your gut instinct, you will know what the right surgeon is for you. Because sometimes you will meet with a surgeon and just walk out that door going, "Nope, not letting that person touch me."
Right.
Or you'll walk out of the room and be like, "Yes, that's my person." So you really have to connect on sort of an emotional level with your surgeon and be okay trusting them and putting your faith in them to do your surgery. So you got to do that preliminary work and kind of find a list however you can, whether you go on Google and look for Beverly Hills plastic surgeon, or wherever you are, Indianapolis plastic surgeon, find a prospective list and then start going through it systematically, looking at things like befores and afters, websites, social media presence, and then going in person and seeing who you like.
Yeah, I mean it's all that, the before and afters. I mean, come on, it is the gallery. You got to look at those results. That's where the action is. That's where you find out what your results are going to look like, and you can, I think it's hard for patients and the public to look at before and afters.
I was just going to say that. It's really hard because there's so many reasons that before the photos even get to the prospective patient, sometimes, they've been altered or they're taken at an angle or at a lighting in a way that's not really representative of what the true result is. So you kind of got to make sure you're looking at standardized photos and that the after photos are not all photos that were sent in by patients in bikinis that they've filtered themselves. That's nice. It's a pretty picture, but it may or may not be entirely representative of what the actual medical photograph result is for the after photo. So be critical in that sense. Like, am I looking at a filtered, pretty, angled, just right, pretty outfit after? Or am I looking at like standardized photos side by side, before and after? So that's one thing. And then the other thing is just making sure that you're really looking at it from an actual result standpoint and not necessarily the flash of the office and the lifestyle and all the other things that are great and fun to look at on Instagram, but really have no bearing on the actual surgical result that you're going to get from that surgeon.
Yeah, I really think the websites are key. I
know, I'm old school. I'm like circa 2008 right here. Like, go to the website, and that's where you're really going to get all the standardized information that you need.
Yeah, I mean, I almost sent out this before and after that I came across on social media because it repulsed me and angered me so much that I was going to send it to everybody kind of in our friend group. But I didn't. But what it was the before was a patient who was frowning, wearing glasses, no makeup, hair not done, looked like they just came in out of the rain and let it dry. And then the after was glasses off, full makeup, smiling, filter. And the comment from the surgeon was, "Oh my God, what an incredible transformation." And I only felt like it would have been better if they'd said, "And you don't even need surgery to get this result," because you don't.
It's like an old school rom-com makeover where you like take the glasses off the nerdy girl and give her a dress and some makeup. She's popular.
And this guy charges over $150,000 for facelifts, and it was repulsive to me. It made me just like smoke came out of my ears because I was like, how can you stand yourself to do that? Like, how can you even possibly put that up there and consider yourself anything but a fraud? I mean, seriously, it's so like insulting to the public to do that, which is why I think you should go to the websites and look for a photograph on a medical background, whether it's black or blue or gray or whatever. I don't care, but the lighting and the backgrounds should be similar.
They should be similar. Medical grade photographs, standardized
It's not
angles.
hard to do.
Yeah, that's what I mean, if you're going to go classic, old school, traditional plastic surgery, that's what that is. The newer stuff on social media with, the smiling, happy patients is great for social media. It adds to a nice, pretty page. It gives personality to the page, but it's not necessarily a great representation of the before and after.
It is for entertainment purposes only, yet I think patients look at social media as the gold standard at this point.
Yeah, that is probably very true.
This week, in fact, I am on my social media trying to post before and afters that are medical grade, that are, here's the blue background, here's the blue background, here's the same positioning, here's the same positioning, trying to really get it right. And it is hard. I am going to admit that, like, even getting the lighting right is hard in an office. All that stuff is hard. But full makeup and a filter with a smile and, versus glasses, I mean, that kind of thing is, to me, it's completely wrong, and patients don't know. They don't know. They can't tell. So that's why, talking about this is really important, because I don't think, you're just not. And of course, this is a surgeon whose board could give a crap. It's not the American Board of Plastic Surgery, because if we did that, you'd get 17 letters from the higher ups in plastic surgery saying, like, I saw your before and afters, you're being reprimanded, we need to talk about this, the ethics committee already has this under, that's how that goes. In these other boards where they're not really interested in ethical considerations, they don't care. So these other specialties are free to advertise however they like. And that's the truth, because nobody's going to reprimand them. Nobody cares. It makes it very hard for patients, and I think it's unfair. Back to your before and afters. That's my little sidebar, and I'll get off the soapbox now. I want to talk about your before and afters, because yours are very standardized. They're very clear, and that's where I think especially the things that you do that I see, and you can comment otherwise, but I see you doing breast reductions in a very aesthetic and incredibly beautiful way that includes liposuction of the bat wing armpits, which needs to be done sometimes with extended excisions,
yes.
extended reductions. I see you doing massive body lifts of epic levels, everything from circumferentials with thighs and upper torso lifts, including the breasts and the arms and all that, to really doing even your facial aesthetic work that you're doing for not only just people that have aging face, but you're doing transgender work. And so I felt like we kind of had to talk about it a little bit, because I was sort of shocked when I was talking to these people in the leadership positions that they just had no clue that you were like over here just kicking ass and taking names.
Well, yeah, I mean, I might, you know why? Because I'm operating. Like, I'm not, that's why I suck at social, well, there's many reasons I suck at social media, but one of them is that, like, I spend most of my days in the OR, and when I get home, I'm really tired. So that's, I'm just here operating. And what I'm doing on any given day, like you referenced, breast reductions, I do a fair amount of those. I really like to make pretty breasts, and that ranges the gamut depending on what the patient tells me that they want. But at the end of the day, I want these breasts to be really pretty. I want them to be beautiful. I want them to be sexy. I want the patients to feel comfortable with these breasts. And if that's a patient who says they want really large breasts and 600cc implants and up to their neck, we can work on that. We can do that. If they just want, hey, I want this to look natural, but maybe a little bit of fullness, not entirely like a natural breast, we can do that too. So I really try and take the patient's input into what they want their breast to look like, and then just knock it out of the park with a really beautiful breast for them, whether that's a reduction, a lift, fat grafting, augmentation, whatever it is that they would need. And then for the body stuff, like you referenced, there's a large amount of body contouring. And it's a lot of liposuction. Usually there's a lot of skin removal, but the goal is still the same: to create a really pretty, beautiful female figure that has, everything that the patients are wanting, a contoured waist that flows smoothly into the hips, a nice, beautiful hourglass figure. That's usually what I'm trying to create with all of the body contouring and abdominal procedures that I do.
And you're damn good. Breast augmentation. Are you under the muscle, over the muscle kind of gal?
I'm typically under the muscle, with a few exceptions. So my transgender patients and my tuberous breast patients are usually over the muscle. In the workout patients or super fit girls, usually subfascial or over the muscle in those patients as well.
And what do you have to say about saline versus silicone implants? Do you put any salines in, or only if somebody has a gun to your head?
Only if they have a gun to my head. Like if they actually come in asking. If I have patients that already have saline implants, I usually suggest silicone to them. And if they have big objections to it, then I respect that and I'll put in the saline. But usually they're like, oh, I was just told that silicone weren't good for me, so that's why I went with saline. And then when you explain the whole logic behind why silicone implants aren't bad for you, they don't leak like they used to, they're usually quite amenable to the silicone change.
Change implants every 10 years or not every 10 years?
Not every 10 years. Unless they are really old implants, especially made before maybe 2012-ish, they may not last much longer past 10 years. Anything I would say made after 2014-ish probably has a fairly good lifespan, and you can extend that 10-year recommendation out a little bit longer. Anything placed within the last few years has a 20-year warranty against rupture, so you got plenty of time on those. Usually I tell people you're going to have these implants exchanged before you hit that mark for cosmetic reasons. Time, age, gravity, pregnancy, aging. You're going to want these swapped out for cosmetic reasons, not because the implant itself has failed.
Last one. Periareolar mastopexy or anchor scar? Wise pattern mastopexy.
Anchor scar. So the periareola, that's a scar that just goes around the areola. It's used to do a lift, to lift the areola up over the implant.
Kind of.
Or you do the anchor, which is around the areola, down the center, and underneath. And Usually my patients end up with some version of a mini anchor to a full anchor if we're talking about a mastopexy or mastopexy augmentation. I will do periareolar in a few like very, very rare conditions when they need it, but they don't need the full vertical. And usually it's in my tuberous breasts. My tuberous breasts usually need a bit of a lift, but they don't need any skin removed from the bottom because that's actually where they're deficient in it. So I do it periareolar, but I have a very specific and special technique I use for the periareolars to really minimize the widening and scarring that you typically see with a periareolar scar. Everyone's like, oh, the scar's hidden because it's in the areola. You'll never see it. False. Those scars widen and they scar and they can look so bad.
Ugh.
So I have a little technique that I've developed that I do to really minimize that widening.
Very cool. Well, I just thought we should kind of do a little roundup after our little trip there, just because I didn't, I think everybody knows what I do. I think that's been pretty well established. I do noses, faces, and breasts are kind of my thing. But, I was very, very happy that you got on those big panels, but I also think that there needs to be a little more of that. There's some experts around Beverly Hills, and I think that getting you on the docket at these meetings is important because you have tremendous experience, and it helps the surgeons who are dealing with the stuff that you're dealing with. And there aren't too many people that are up there talking about it.
Right. Yeah, I'm here. Throw me your hardest breast case. I'll take it. Wait, nope, that's not hard enough. Give me another one.
Yeah, well, and you do great with them. So anyway, just wanted to round that out from our meeting and let everybody know that you're available for panels as opposed to available for parties and come to your kid's birthday party. But no, I mean, for the panels, it's really important because that's where you get to discuss that. And for our listeners who, don't go to medical meetings, when we're at these meetings, it is it's a lot of information flowing back and forth.
Oh, yeah.
And, it's really good.
Really good stuff. I mean, that's where you really share your techniques with your colleagues and you learn and grow as a surgeon. Even if you're the one speaking, there's like always something you can learn from being around your colleagues doing similar things or having similar problems. Yeah,
it's a big deal. And these are, with 17 or 18,000 participants at this meeting, it was high impact and there was a lot of discussion. So not so much in the rhinoplasty sessions because all 12 of us really enjoyed each other's company.
Yeah, I know. All of you little masochists hanging out together.
I know. It was, I think it was Mike Nyack that was like, yeah, man, those cases you do, like, you're crazy. Those are impossible. Like, what are you thinking? I was like,
yeah,
hey, it's the real deal. Got to do them. Anyway, this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.